Hi, my name is Jeff Houck, and this is a collection of my research, May of 2021, that supports the idea of a psychosocial model in physical therapy. This research really addresses 4 different challenges: the influence of PROMIS outcomes on practice, using these scales and other measures, the support to the expansion from a biomedical to a biopsychosocial model, some issues related to provider adoption of the model and these kinds of measures, and then how to translate this to practice. So why are measures important? Really, measurements allow us to look at things through a different lens, or they expose different patient traits to us that then allow us to hit those as targets or learn about how we're affecting them clinically. So the Patient-Reported Outcome Measurement Information System, or PROMIS, does just that. These set of measures is a set of person-centered measures that evaluate and monitor physical, mental, and social health in adults and children. It can be used with general population and individuals with chronic conditions. So this is ideal for us looking at patients from a person-centered perspective, where instead of looking at disease-specific effects, we're looking at the interaction of different diseases, habits, and patient preferences. In summary, the patient-reported outcome measurement information system are person-centered, and in other words, they don't really mention the person's disease or specific diagnosis throughout the questions that they administer to the patients. Instead, it's person-focused. It allows us to monitor different domains of health, so each measure is unidimensional or only focuses on a physical health measure, a mental health measure, or a social health measure. And they're normed to a reference population. Usually it's the U.S. Census, so it gives us a normal reference value, and it means that therefore you can get a measure that's better than average or worse than average than the U.S. Norm, or another patient group like patients with chronic conditions. So essentially what that means is that a 50 will be equal to the average. A 10-point change is 1 standard deviation in either direction. So here's a good example. This is a histogram of physical function that we collected across physical therapy patients at our clinic. We can see that at a 50 here, the patient histogram is slightly shifted to the left or lower than normal, so they have lower physical function than normal. And the average curve that we might expect is here in green. And so our group of patients is about a half standard deviation below average, and we can see that it's kind of shifted to the left with really very few patients above average. So these new scales, by referencing to the U.S. population, give us a sense of what the severity of our patients are across the whole population. So what domains can we pick? Well, there's lots of different domains in the PROMIS collection. And so for these first studies we're going to look at in the physical domain, we're focusing on pain interference and physical function. And in the mental health domain, we're focusing on depression. So I was fortunate enough to collaborate with researchers at the University of Rochester. This is an example of one of our studies. We looked at determining success and failure in people after foot and ankle surgery. And in essence, we wondered what pass threshold, or what score on their physical function, pain interference, or depression would be the point at which they decided that their symptoms would be acceptable, or their symptoms would be successful, and we wondered if those were the same concepts. So in other words, if my symptoms are acceptable, that means I have some symptoms, but they're not too bad. Or if I consider my surgery a success, that may be slightly different or the same. So these are the receiver operator statistics that we have here. And essentially what that means is that a 0.6 or 0.7 or above is better. And we're looking at the ability of these different scales. PF is physical function, PI is pain interference, and the D stands for depression. we're looking at the ability of those scales to really determine these two different judgments by the patient, whether they have acceptable symptoms or that their treatment was a success. And we can see here is that essentially the preoperative PROMIS values were not that good at predicting their patient acceptable symptom state or success, at the follow-up point. However, at the postoperative point, the PROMIS scales were above 0.7 in terms of their area under the curve on the receiver operator analysis for all three measures. That includes the two physical measures, physical function and pain interference, and the mental health measure, depression. And what's really surprising about this, across both time points, the mental health scale, depression, was equally as predictive at pre-op, at the post-op follow-up, and at the post-op follow-up, the three scales were equally as predictive of either patient acceptable symptom state, which is what we're showing you here, or success, which we published in a different table in this paper. So what's surprising is that the mental health scales had just as much predictive power in terms of determining whether a patient judged themselves as an acceptable symptom state or whether they considered their surgery a success. In this study, we're looking at the pattern of recovery after an ankle fusion and also pain. So we're looking at physical function and pain. In this first graph, I'm showing you physical function on the PROMIS measure. We can see here on the y-axis is the T-scores, where 50 is average, and we can see the pattern of recovery over nearly a 1-year time period, that initially that the average scores are over a standard deviation below normal. Immediately following the surgery, the patients are worse off in terms of physical function, exceeding 3 standard deviations from normal, and then essentially they recover to just slightly better than where they started, but still remaining a standard deviation below normal. What's interesting about that is this average out just below what most patients would consider acceptable in previous studies. In terms of pain interference, we can see that here on the y-axis is the pain interference score, T-scores, and we can kind of note that the US average here is 50, and that 1 standard deviation above is really in this acceptable range here, and that the patients start over a standard deviation worse than normal, so quite significant pain interference pre-surgically, and then that gradually decreases within a couple months after surgery, and then remains in that kind of acceptable range that we can see here. And so the question is, for these patients with this end-stage foot procedure, an ankle fusion, which you can see up here to the right, is this adequate outcome? Or we know that they have good pain relief, but the question remains is, could behavior change techniques change also their physical function? In this study, which is not published yet, we're looking at ankle fractures and the same 3 measures, the physical function, pain interference, and depression. Only this time what we're doing is we're looking at the pattern of recovery after ankle fracture surgery, and then with those patients divided into patients who had at least once in their 1-year follow-up an episode of depression that was moderate or severe or below that in terms of the PROMIS depression scale. And we can see that the patients who never experienced moderate or severe depression during their recovery are actually having a better functional outcome than patients here in gold who did experience moderate or severe depression during their recovery period. And here we're looking at the same information for pain interference. We see the pain interference measure here on the y-axis, and in the dark blue we have the patients who, in the gold is the patients who experienced moderate or severe depression during some point in their recovery. We can see that they have more pain experience than the patients who only experienced normal or mild depression during their recovery. So then we can kind of turn toward what the PROMIS scales tell us about how effective we are working with foot and ankle patients in terms of these three different PROMIS measures. So two physical function measures, physical function and pain interference, and then the mental health measure of depression. So this is nearly 200 plus patients that were just randomly selected from different foot and ankle diagnosis, and we can kind of see the diagnoses here: Achilles rupture, fracture, ankle pain, ankle sprain, foot pain, Achilles non-rupture. And these are their different changes in physical function from their initial visit to the last follow-up that we had available to us. And we can kind of see here that essentially most of the patients achieved greater than a 4-point change in the PROMIS physical function score, even across all the different diagnoses. If we look at pain interference, the results are somewhat more mixed. So less pain interference is better. And so we can kind of see here that they all had some minimal improvement in pain. Average, it looks like it's around 4 points, or 4 T-score points, with the biggest improvement in the ankle sprain patients. And then in terms of mood or depression, the change in depression was more mixed, with less improvement in depression occurring in some patients and more in others. So what this is telling us is essentially that even though the depression scale is kind of equally as predictive of PASS, in terms of our current approach to treatment using this one mental health scale, it doesn't show very strong effects in terms of our outcomes from physical therapy. So what does this indicate to us? Even though it's just one mental health scale, it really suggests that exploring more mental health scales and exploring effects on these mental health might yield some positive outcomes. And essentially, it also challenges us to the idea that maybe we could have bigger effects on physical function in some end-stage foot and ankle procedures. So in this next set of slides, we're asking the question, could expanding our biopsychosocial measures also improve our outcomes? So again, we return to the set of PROMIS physical, mental, and social health measures and select an expanded set of measures, both physical and mental and social, and evaluate those clinically. So in this case, we used pain interference, fatigue, and physical function, and we also selected negative mental health scales, anxiety and depression, and then a positive mental health scale, self-efficacy of managing symptoms, and finally a social health scale, satisfaction with social roles. And in patients with hallux valgus, we ask the question, which measures are predictive of perceived physical ability and pain? And here what we were doing is evaluating performance-based or capacity measures of the foot and ankle and comparing those to their perceived psychosocial variables. So these are the capacity or performance measures we used. So you can kind of see here we have an instrumented system where we measured first MTP flexion, and then here in a more practical or functional test, it's a paper pull test. So we have the same instrumentation system with a piece of cardstock under the big toe, and we're pulling the cardstock out and asking the patient to push down as hard as they can into the floor and measuring how much force it takes to pull the piece of paper out. Then we also had 3D motion analysis and EMG on the foot during a heel rise task. And here we're measuring heel height and the number of repetitions of the heel rise. And then we compared these measures to their patient's perceptions of their physical function, pain interference, fatigue, self-efficacy of symptom management, and satisfaction with social roles using the PROMIS measures. And here we're showing you some of the correlations between the impairment of the first MTP force output and physical function. We can kind of see the correlation there, the scatter plot. And here we're looking at physical function and heel rise height. We can see then also a nice correlation. And then finally the psychological or mental health scale, self-efficacy of symptom management, and physical function. And we had similar correlations for pain interference. You can see they're moderate to high correlations in these patients with hallux valgus, suggesting that the psychological measures are equally as predictive of things that we would consider important in terms of outcomes from orthopedic procedures like hallux valgus correction or any kind of conservative treatment for these patients. And so these physical function and pain interference is equally influenced by performance measures like strength and a functional activity task like heel rise, and a mental health scale like self-efficacy of symptom management. So we also look at this expanded set of measures in primary care. We could ask the question, which measures are predictive of an acceptable physical ability and pain? So here we have the physical health measures, which we typically focus on in terms from a biomedical perspective and from an orthopedic perspective, be physical function and pain. And then the psychological measure here is self-efficacy of symptom management. And so just using these three measures in patients seen for physical therapy in a primary care environment, we have this particular study we published in 2018 in Archives, where we're looking again at the ability of these three different measures to distinguish between an acceptable symptom state and an unacceptable symptom state. And we can kind of see here that essentially pain interference, physical function, and symptom management all were above 0.7 and had equal ability in terms of predicting acceptable symptom state. Again, reinforcing the importance or equal importance of self-efficacy as perceptions of physical function and pain interference. And then in the patients attending outpatient physical therapy for MSK problems, we asked what's the prevalence of physical and psychological health measures. And in particular, we were interested in the prevalence of abnormal or physical function and pain interference and fatigue that was above or below the U.S. average using the PROMIS measures, and then also about self-efficacy of symptom management, with the idea being are these additional measures, there's this expanded set of measures detecting important patient experience that could be a potential target for physical rehabilitation. And the expansion really includes fatigue and self-efficacy of symptom management. So we typically measure physical function and pain interference. And so the three we're going to show you here is physical function. So the red means that the patients were half standard deviation worse than the U.S. average. The yellow means that they're within a half standard deviation of the U.S. average, and the green means they're better than the U.S. average. And so in a large set of patients attending our university clinic, we could see that about a little over half were worse, at least a half standard deviation worse than the U.S. average, and only about 20% were better than the U.S. average. And then in terms of fatigue, what's I think surprising is that nearly 42% of the patients were at least a half standard deviation worse than the U.S. average, but a larger set of patients were better than the U.S. average. And then when you think of self-efficacy, the story's a little bit different. We think about worse than other patients with chronic conditions. We can see that only 19% of the patients were equal or better than other patients with chronic conditions. But nearly 46% of the patients were worse than a half standard deviation of other patients with chronic conditions, suggesting that both fatigue and self-efficacy identified an important patient experience that was worse than average, either than their reference population, in just a large set of patients being seen in physical therapy for MSK problems. And in this final kind of pie chart, what we're showing is that how these four measures combined. And importantly, what we're looking at here is first, how many of the patients were really in the clear or above the U.S. average on all four of the scales. And we can kind of see here is that they were within a standard. 19.1% of the patients were within a half standard deviation of their reference population on all four scales, meaning that likely their reason for coming in wasn't severe patient experience in terms of self-efficacy, fatigue, pain interference, or physical function. And essentially only the green here indicates how many of the patients had really only symptoms that were restricted to physical function or pain interference. And what we can see is that only 20% of the patients had only symptoms that were greater than a half standard deviation worse than their reference population in these two domains. In essence, the majority of patients coming in, either here we're showing in red, had all four scales were worse than the reference population, or they either had fatigue plus pain interference and physical function, is what we're showing in the blue, or they had worse self-efficacy by half standard deviation in addition to physical function and pain interference, suggesting that the expanded set of measures really applies to greater than 50% of our patient group. So in this next question, we're asking, in patients attending outpatient PT for MSK problems, do PROMIS outcomes predict the risk of persistent MSK pain? So we use the Keel Start Back tool to predict risk of persistent symptoms, and you can it's cited here. It's a fairly new scale, similar to the Start Back tool. And we looked at a set of 7 PROMIS measures, 3 physical health measures, physical function, pain interference, and fatigue, 3 mental health measures, 1 positive mental health measure, self-efficacy for managing symptoms, and 2 negative health measures, depression and anxiety, and then 1 social health measure, satisfaction with social roles. These were 94 patients that were seen in 2 distinct rural outpatient orthopedic clinics in Oregon. And on the MSK tool, essentially the 46.8% were classified as low risk, 43.6% medium risk, and 9.6% high risk. And we're looking at the difference between the PROMIS scales being able to predict medium or high risk versus low risk. So in the multiple linear regression models, pain interference and fatigue were the key physical health measures that were predictive of the distinction between low and high risk, with an R-squared of 46%, all significant. And then of the mental health measures, depression and self-efficacy were the significant. However, we can see, we're looking at the standardized coefficients, that self-efficacy had more pull or had a bigger impact on their prediction of whether they were low or high risk than depression. A slightly lower accuracy than using the physical health measures. Then we considered all 7 measures together. The 3 measures that were the most selected by the logistic regression analysis were self-efficacy of symptom management, pain interference, and fatigue, all with relatively equal weighting in terms of their predictive power. It nearly explained 50% of the variance in predicting risk of low back pain, of persistent musculoskeletal pain. So what this suggests is that really physical health measures and then this kind of set of biopsychosocial measures of self-efficacy and these pain interference and fatigue had value in terms of predicting or correlating with which measures on the MSK tool or scores on the MSK tool predicted persistent low or higher risk of persistent symptoms. So these scales really push us toward the potential to use psychosocial measures in addition to physical measures in understanding our patient experience. And they really pretty much strongly support this idea that if we're trying to understand what's an acceptable symptom state for our patients, the mental health scales have just as much predictive power as physical health scales, and also performance and impairment measures. And then also that if we're trying to understand another score that's been validated to suggest risk of persistent symptoms in a really global population of diagnoses of patients with MSK problems, that the PROMIS measures, which are person-centered, meaning they're not disease-specific, and they have the ability to capture all these unidimensional domains, that they essentially can, give us some ability to predict persistent symptoms similar to a tool that's specifically designed for that. And so the next piece is this a good strategy from a provider's perspective? And, when I was working with providers, there's a lot of challenges in terms of integrating this kind of information with other clinical tests and impairment-based tests for clinical decision making. And so, which I think, and I think this is justified, most clinicians say, hey, convince me that this is really helpful, because it kind of adds complexity to my approach to patients. So I'm starting with a study that really kind of, I think, has a big impact on me, and it's, we're looking at by a therapist's ability to identify psychological factors just based on their interpretation and the patient interviews compared to self-report measures. This is published in Physical Therapy in 2018 by Dr. Bruner and his colleagues. And we're showing here is the columns of this table are the start back tool scores based on the paper measure, and then on the rows are the therapist's judgments just based on their interview of which patients were low, medium, and high risk for persistent symptoms, and this is specific to low back pain. And the blue boxes are where there was good agreement between the tool and the therapist, and we can kind of see is that the majority of patients fall outside of the blue boxes, where only 41% of the 49 patients were matched correctly. And in this particular study by Gardner et al., we're looking at when therapists took this kind of approach to asking patients what their real goals were, and this is in patients with chronic low back pain. I think there's somewhere around, a little over 20 patients in this study. What were their goals when they were allowed to discuss a goal-setting paradigm, interviewing process with them, and the percentage of patients that had physical activity goals, workplace goals, coping skills, relationships and sleep energy kind of goals. And what we can see is that pain is not really a strong goal for patients, or pain reduction, and that most goals related to some type of physical activity, but very, very few related to coping skills. And so taking that information together, we're looking at, during treatments in outpatient PT for MSK problems and primary care providers, do providers find the PROMIS measures helpful? So given these kind of background where we know that we're not really accurate in predicting what psychosocial experiences our patients are having, do providers, when they're given PROMIS T-scores, do they think that that's helpful? And then let's kind of look at that here. So, and we have two different kinds of providers that we evaluated this in. PTs, and MD providers. So these were the scales we assessed in both primary care and physical outpatient clinics. And then we asked providers to rank their judgment of the helpfulness of these scales on a 0 to 10 scale. And then we also conducted semi-structured interviews. This is how we presented the PROMIS measures to them. We used kind of this report card format where we have the scales kind of listed here on the left, and then we kind of shaded the scales when they were at least a half standard deviation worse than their reference population as red or darker red, and when they were above average for that reference population, we give shades of green, and then with standard deviation below normal but close to normal, we put in the yellow zone. And then we would ask them to complete this 0 to 10 ranking here at the bottom after we presented this information to them. We would X the scores here on the chart and then write the numbers of the actual T-scores for them. And then we also provided interpretation of the scores if they asked for that. So in an excess of 300 patient visits, we asked, you can see the ranking of helpfulness is here in the dark orange, and the percent of the sample that answered 0 to 10, which is here on the X, is shown in this kind of line graph. And we can kind of see that about 67% of the MD providers ranked helpfulness above 7. And we happened to also ask patients the difficulty of completing these measures on the iPad, and essentially where greater difficulty would be a 10 and lower difficulty would be a 0. We can see that most patients, or 75% of the patients, rank the difficulty at less than 2. And then when we asked PT providers the same question about helpfulness, and here we had 58 different encounters across 5 PT providers. We can kind of see here that the helpfulness is kind of a greater range, where about 70% of the encounters, the providers ranked at a 7 or greater, and then the rest of the encounters were between 4 and 6. So for the majority of encounters, there was some helpfulness in terms of these scales, but not for all of them. So what's evolving is that I think in the semi-structured interviews is providers said that the scales would be more useful, that both the MD and the PT providers, if there were actionable treatments based on different threshold or scores from those particular PROMIS measures. And so what we've been doing then is evolving training programs that provide different types of targets for the different measures, including the physical function and pain interference, fatigue, self-efficacy, and satisfaction with social roles. So that kind of presented us with the challenge and also this expanded view of the psychosocial measures for physical therapy and MD providers was positive, but not a slam dunk, because there was more work to do in being able to translate those measures to practice and helping providers interpret them. So in this particular case, we looked at the ability of these scales to detect change in patients after a single visit. So the idea here is that rather than doing more intensive treatments, we would try to see if we could develop one-time kind of treatment that can help us with patients that have high risk of persistent symptoms with low back pain, and see how the PROMIS measures and psychosocial measures measure outcome. And this was a type of kind of flooding treatment based on cognitive functional therapy strategies that we tested in just a small group of patients. So this is more of kind of a pilot study that we're just kind of doing proof of concept in terms of looking at, how these outcomes kind of work. So in patients with moderate or high risk of persistent symptoms, we asked, does a single visit focusing on exposure result in a change in risk or improvements in patients' PROMIS outcomes? And again, it's a proof of concept study where we did a pre-assessment of the Start Back tool, feared of daily activities questionnaire, PROMIS outcomes, and then after a single intervention, we called them 7 days later and re-administered some of these different scales. And so pre-treatment, we can see this small group of 20 patients here, where there was moderate risk and high risk was the admission criteria, so we didn't really admit people who were low risk. We can kind of see that 65% of the patients, or 13, were moderate risk, and 7, or 35%, were high risk. And then at the post-treatment, we can see that, total in the rows here. Basically, 45% of the patients had shifted to low risk, and we had 50% of the patients who were high risk or moderate risk, and only 1 patient was high risk. So about a 50% improvement in patients' risk category. And we can kind of see here the 4 PROMIS measures we used, which included pain interference, physical function, fatigue, and self-efficacy. The pre-treatment values are in dark blue. The post-treatment 7-day follow-ups in hash, and then the T-scores for each patient, our PROMIS scores is on the y-axis. We can see that they had less pain, higher function, lower fatigue, and higher self-efficacy, suggesting the PROMIS measures were effective at documenting a 7-day outcome. So finally, we're kind of getting into more training aspects here. And what are physical therapy students' reflections and observed communication skills during a lifestyle telehealth counseling session? So during COVID, we were disrupted in terms of our ability to actually interview in person. So this gave us a unique opportunity to look at recorded Zoom videos of physical therapy students trying to learn motivational interviewing skills or these specific communication skills with patients, and what that process was like. And so we looked at outcomes early versus late training. So we looked at basically their Zoom videos during early training and late training, and we looked at both their reflections. So they were asked to write reflections during this training, and then looked at that qualitatively. And then we also looked at the video recordings and scored them for the different communication skills that they were observed on their video recordings. And so in the reflections, the early reflections expressed really difficulty, really just with the communication skills. Here's an example that has been frustrating at times, feeling like I spoke too much or didn't even say the right words, missed something huge, or spent time on things that may not even matter. And this kind of reflects the difficulty of understanding, like, what's the difference between an affirmation and a reflection, or when to use an open-ended question versus a summary. So this is that questioning of the early trying application of these MI skills and use it during the videos. In later reflections, the focus was more on the spirit of MI, or the spirit of the communication skills. So rather than talking about the technical details of like what to say and when to say it, it was more on trying to get things like empathy or evoke discrepancy or things like that, which is kind of the whole goal of the communication skills. So here we can see in the reflection, most important thing is to empathize completely with the patient's point of view and to truly meet the patient where they are at. So here's like the goal of doing the communication skills. So then when we looked at the video recordings, the technical kind of use of skills across from early to late and how that matched up with the reflections, this is the kind of percent of the frequency of open, closed, simple reflections, complex reflections, and affirmations, which are all kind of basic communication skills in the motivational interviewing techniques, versus late, we can see there is this real change in the frequency of these different skills, especially this increase in open-ended questions, in some kind of status quo, a small increase in closed-ended questions, an expansion of reflections, and especially complex reflections. And then some affirmations stayed the same. And then here's a comparison to a single video from an expert interviewer, a psychologist. Essentially, we kind of see that really the real difference here is a reliance on simple reflections is like the biggest difference, and this kind of potential for increasing complex reflections. And this kind of fits with our experience using motivational interviewing techniques. Is the later skill to develop is kind of simple reflections and complex reflections, and these potentially yield the most kind of deeper psychological effects from these treatments. And it's interesting that at the first level, just understanding how to ask open-ended questions, but this need to kind of improve the ability to use reflections is necessary for really effective, more psychosocial interventions. So that summarizes some of our experience with the biopsychosocial approach and the PROMIS measures. Their comparison to kind of some biomedical measures like performance measures and capacity measures, what we've been learning about provider adoption and trying to train a new therapist to use these approaches. Thank you.